Folks, please come on down and take your seat for our seventh and final session of the conference. Just take another moment or so here before people can come. Getting the final cookies off the tray and back. We will conduct this panel in the way that we have all of the others. We'll have Sachs scholars here who will collect your questions and comments in the basket, and then we will be reading those. And this has been a very full 2 days, but I think we have now just an enormously rich panel for the final 2 hours of the program. And I look at this panel, and I think any conference that I have been to where one would address the stigma of mental illness would be absolutely thrilled to have the panel that we have right now. So thank you all for being here, and we look forward to a wonderful discussion. So Dr. Lieberman.
Thank you, Steve. Good afternoon, ladies and gentlemen. My name is Jeffrey Lieberman, and I'm delighted to be attending the meeting and moderating this panel. I want to express my gratitude to Ellen, Steve, Chris, and everyone that's involved in sort of organizing and participating in this session. It's something that's extraordinarily important, long overdue, very timely, and although it's clear from the discussions over the past 2 days that there's a lot to do to make this sort of into the situation that it could and should be. Things are moving in the right direction, and there's gathering momentum. So what we thought we would do would be to ask everybody to individually... Well, let me just stop before. The topic that we've been given has to do with issues relating to stigma of mental illness in university and student populations, and obstacles or difficulties in terms of providing optimal care. And so the questions and the discussion are going to focus on kind of obstacles or barriers to care, which includes stigma, to possible opportunities to try and address those, and then strategies by which this could be affected. In a minute, I'm going to ask each person on the panel to briefly introduce themselves and talk about sort of how they come to this area of interest. And then we'll begin by posing some questions to the panel to comment on, and then entertain questions that you all will submit to Steve. So to begin, I'm Jeffrey Lieberman. I'm trained as a psychiatrist, and I spent my career practicing and doing research mainly in the area of schizophrenia and psychotic disorders in terms of psychopharmacology and neurobiology. I recently became elected president of the APA, and I've gotten involved more in kind of a national policy and legislative approach to try and influence how our country provides health care, finances it, and so forth. And my home institution is Columbia University. So let me begin with Jennifer.
Thank you. My name is, can everyone hear me? Raise your hand if you can't. Aha, just checking. My name is Jennifer Hoff. I'm the co-founder of the Hoff Family Foundation. My story includes raising a mentally ill child from pediatric side of that illness, which included multiple pediatric hospitalizations, institutionalizations, and he was in a facility from age 12 to 18. Upon graduating at 18, he entered the world with the civil rights on and became part of that revolving door that we all hear about for those who don't have insight or don't think they're sick. So he currently is in Wasco State Prison with crazy tattooed on his forehead because that's not illegal, but it is illegal to walk into a bank with a sticky note demanding $1,000. So we fight and push for policy in the areas of decriminalizing the mentally ill of all ages, because it's happening on the pediatric side as well. We're in the process of finalizing our 501. So we're just excited to be here and be part of this journey. Our son was able to attend college for 3 weeks, and there's some stories there too. So, and I have some time that I spent as health educator of junior college in California for quite a while. So I see things from many perspectives, and I just am glad to participate.
I am Reina Juarez. I am the Director of Counseling and Psychological Services in the University of California, San Diego. I have dedicated my life to work with the students to empower them for their success and for their personal development while they go through that wonderful and challenging time in higher education. And during that process, I have confronted over and over again the stigmatization that happens in an individual, in a group level, in a community level, in an institutional level. And I am dedicated also in changing policies and guidelines and anything that has to do with a perspective. And I was thinking that until we know much more about the brain, because it is still our frontier and we are in the decade of the brain, it's going to be very important that until we develop special treatments that are targeted for that individual, just like cancer, that they are finding out that it's not one cancer for all, that there are many specifics for the disease that is very personalized, and that now they have the micromolecular level genetic treatments, the same way I hope one day we can match treatments for the condition in the brain, and that with one blood test we can find so much that we don't know yet. But until that time comes, I am dedicating myself to breaking through the barriers of stigma and discrimination and all the distortions that happened, including the criminalization of those suffering from many disorders and conditions. And in the meantime, I have been enjoying immensely being in this institute because, as we can see, what we also need are role models of success. All of us that can live with mental disorders and be quite incredible, brilliant, and accomplished people and fulfill people with lives that are full of what is good, the good life, our flourishing. So with that, I pass it to my colleague here.
Thank you, Raina. Can you hear me? Mm-hmm. Great. And thank you for talking a bit about research and development of better therapies that are safer and help people in an individualized way. I'm Brandon Staglin. Well, first I want to start by thanking Ellen Sachs and Stephen Benke for inviting me to speak at this conference along with such a distinguished group of people. And thank you to Dr. Liebman for chairing this panel and for your support of our work at IMRO and One Line for Research. I wanted to bring up IMRO in that what you just mentioned was what we do at IMRO, so thank you for talking about that. I'm Communications Director for International Mental Health Research Organization, or IMRO. I do mostly web-based communications and digital media for this organization, which funds scientific research into better therapies and preventions and hopefully someday cures for major mental illnesses such as schizophrenia, bipolar disorder, and major depression. So I was diagnosed with schizophrenia in the summer of 1990, the summer after my freshman year at Dartmouth College. And I was able to recover pretty quickly because I got treatment within a few days after my psychotic break, and I was lucky in that regard. I was able to return to Dartmouth about 6 months after my diagnosis. And while I was there, I was able to succeed academically in that I graduated on time with honors, with degrees in engineering sciences and anthropology. But the self-stigma that I felt and the fear of discrimination that I felt made me want to hide my diagnosis from everybody who didn't already know about it. That meant my friends and faculty and so forth. So that was exhausting, trying to police my thoughts and my behavior to keep that away from anybody who might notice anything, quote, strange in me. So I think my greatest asset in my academic success was my relentless ambition and self-discipline to succeed in my goals despite my mental illness. But my greatest enemy was anxiety, specifically mostly due to self-stigma and fear of discrimination. So I'd love to tell you more about any of this. So if you have any questions, I'm here to answer them. Thank you.
Hello, my name is Miriam Feldblum. I'm the Vice President for Student Affairs and Dean of Students at Pomona College, which is part of the Claremont Colleges. It's a small college of 1,600 students. And I too want to start off by thanking Ellen. Ellen came to Pomona College in the beginning of last fall. And we had the whole first year, and actually it was a whole community reading her book, her memoir, and it was a transformative experience for the campus. I'm also a professor of politics at Pomona, and I came to student affairs from the academic side. And I started off as a special assistant to the president at my last institution, and I realized that a lot of issues, I was looking at diversity issues and some other issues, and it was problematizing the students rather than taking a look back and saying, what was the issue with the institution? And that there were often systemic patterns going on in which the students found themselves and had to grapple with what was going on in the institution. So that's very much what has informed my approach to student affairs, is looking at what are we doing as a community and as an institution, and thinking about the holistic approach to student development. So when institutions and colleges like Pomona want to focus on student success, well, student success includes student wellness, student mental health, student life inside and outside the classroom. I come from the perspective that colleges and universities are the greatest nexus of change that we can have in a society, that we're generators of knowledge and change. We are trainers of leaders. So I think that we're in a really important place to impact societal change, and we have to start with institutional transformation and supporting the students. So I'm thrilled to be here on this panel and to be here for this conference.
I'm Ken Hubble. I guess we met yesterday. It's great to sit beside Miriam here because we both came from the academic side of the house. As you heard from me yesterday, I'm actually an architecture for faculty member who migrated into student affairs in 2001. And I also explained yesterday that both of my children who went to college presented with schizophrenia, one in high school, one in college. And I suppose that was the principal motivation for me to move over to the student affairs side of the house. Like Miriam said, I think universities are, shall we say, the sweet spot, as Dr. Felder and I were talking about before. It's a place that, if it's used well, can be a foundation for productive lives beyond the university. In order to do that, I think, like I said yesterday, the university simply isn't the simple sum of courses and credit hours you take for a degree. It's about much more than that. It's about the whole student. So I look forward to a time when the universities will embrace this larger vision of their mission. And I think we're at a moment perhaps where we can make it happen.
Hi, my name is Janet Shortle, and I'm also here from Cornell University. That's why we're smiling a lot, as it's like, I think, about 7 degrees at home. So we have loved being here. I'm on this panel because one of the places of responsibility under my office is to coordinate the university crisis management system and also the community support network. And just in a nutshell, we have a crisis manager on call 24/7 throughout the entire year. And when a student surfaces with a medical emergency, and the most traumatic for the students that I know I've personally interacted are students that go into our health center and are either involuntarily or in that moment voluntarily transported to the hospital because of a mental health emergency or physical health. Crisis managers are sort of that frontline human presence to say, to go to the hospital in some occasions, and many occasions actually to bring contact solutions or books, or just that normalizing, like, your life just got disrupted in a big way. Let's start at the really basic level. What do you need in the next 24 hours? Assuring them that their confidentiality will be protected, but that we would be in touch with their professors and their classes so that they don't feel overly anxious about that, which our students always are. And in a sense, to begin a bit of a friendship that just normalizes that we respond the same way. And when I hear Brandon's sense of isolation, our protocols for responding to a physical or mental health challenge are exactly the same. And I think through those networks, when we're often at the hospital, I feel like one of the early conversations with a student, perhaps if this is their first hospitalization at Cornell, is to explore with them who are their network of support. Who is that person or community that they might be able to take a risk in just creating something so when they come out of the hospital they don't feel quite so isolated. But it's very much driven by the student telling us what they need and what they want. And so it can be a very empowering experience at a time that's sometimes very disempowering and very frightening. And I think it's meant a great deal to students when they're aware that no one knows where they are, that there's one person who they have no history with, but who's just there just to check in and see how they're doing. So it's more or less a system of trying to connect them and their families, and that's the second part. So a family arrives, their son or daughter may be manifesting an illness that they have no previous connection with. They're confused, they're alarmed, they're sometimes in various emotional states, and they sometimes, without direction, start picking up the phone and calling people. That's not always a bad thing, but sometimes it can really be to the disadvantage of their son and daughter to start speaking to this dean, this professor, this office, and then have their son and daughter really upset the next day when they realize how much communication has happened without them being directly at the center. So the first thing we do with a parent is, again, start with the really basic level of services. I understand that you've just gotten a call that your son or daughter's in the hospital. Can I help you make hotel arrangements? And just try to slow down the process. And it sounds like such a simple thing, right? But when you're in the car as a parent, someone just calling you as an ambassador of the university to say, can we help you with your basic needs? I can't tell you how effective that is at those parents really hearing that we're partnering with them. And then begin to talk about, there is this streamlined process. You don't need to call anybody tonight. Your son and daughter's professors will be contacted. You don't have to worry about their classes. What you need to worry about right now is what your son or daughter needs from your heart and your care, and we're here to be right at your side. The community support is sort of the other side of that. So if I'm a roommate of a student who is in the hospital, and I know something of the story because my roommate told me a little bit of that story, and by the way, there's 3 other people, and we don't really feel like we can tell anybody else because this is confidential, and this is my good friend's story, but frankly, we're out of, what do we do when this person returns to our residence? And so another team that's a combination of student affairs, counselors from the counseling service, and then we always call them just kind of your good citizens. We formed this team about 16 years ago where we thought, you know, when something happens in the offices across the campus, if you kind of look, there's always 1 or 2 people that everybody seems to gravitate towards. You know, they're just the person that people just trust instinctively. What if we were to form a committee where it is those people, plus therapists, plus student affairs folks, and try to cross-train each other about how we can be most supportive of communities when they're in crisis in response to a trauma. I think it is so much a factor of more and more students willing to disclose, unlike the isolation I think you spoke of, Brandon. Many of our students will tell their roommates or their hallmates what they're challenged or struggling with. And then those students are left with, now what do we do? So it's, in many regards, it's not rocket science, but it is, again, normalizing, well, how would you respond to a roommate or hallmate that was coming back from having been hospitalized for any other number of illnesses or challenges? What is your primary role in their lives, and what is not your primary role? And how do you kind of work with the network of support and truly understand that your role as a friend is primary when that student returns to your community? Your social connection is primary to them feeling as if they're really welcomed and included in our community. And the fact that we normalize it by not just having therapists, so we don't always make it just a clinical issue, but it's a community issue. So if the Director of Student Services of ILR comes out with us because she knows that a student roommate, we're starting to normalize that together we can figure out how to be good citizens to each other, so long as we know where the resources are and how to really, hopefully, help people to find those resources. What I have found is oftentimes when you're responding to a community that's supporting a student, not always, but often, there's another student in that community that's also either experiencing symptoms or is at risk, and part of their connection of support to the student is they share that sense of vulnerability. So when we're meeting with those communities, we're also just doing a little check about who's sitting in the room and what's going on for them, and did this hospitalization kind of destabilize their life in some way? So expanding those networks of support is critical.
Thank you, Janet.
Thank you.
Becky?
So since I've introduced myself several times, I haven't really talked a lot about my personal story. And so I'll share, when I was in college, I was experiencing depression, but didn't know what it was called at that time. My friends became very concerned about me and talked me into going to the hospital. I did, mostly as to make them happy, because I clearly wasn't happy. I had no idea what was wrong with me. I got admitted to the psych unit. I've never been around anybody that had a mental health problem. And we went past the secure unit, and there were people that were screaming behind the door. I'm not quite 19 years old, never been in the hospital since the day I was born, and I'm scared to death. Because all I see are these people that are screaming and saying things that don't make any sense. There was nobody there to tell me what was happening. And so anyway, I met with a psychiatrist, and it's really funny the things that you remember and you don't remember over time. The one sound that I cannot get out of my head is the sound of his keys jingling in his pockets as we walked through different locked areas. I met with him, and he told me basically that I had to move back home with my parents or he'd court commit me. Now, I have no idea at this point in time what court commitment meant, but I knew it wasn't a good thing. And amongst the patients, the conversation was that he had a reputation for court committing people. And so I knew that I had to do whatever I could to get the hell out of there. And so within 2.5 days, I moved back home with my parents, which was not a good thing. We had a very contentious relationship. It was not a good place to be. And 6 weeks later, I attempted suicide. I did not tell my parents. I overdosed on aspirin, which I don't recommend, by the way. And I was up all night and sick because of overdosing on the aspirin. And I come from a large family. I have 4 sisters and 2 brothers, and I'm the oldest. And we only had 1 bathroom in the house. And I did not want to go upstairs to throw up. So I was throwing up into the washer so that I wouldn't leave a mess anywhere. So the next morning came, and I grew up Mormon, and we had family prayer before everybody left for the morning. And I was supposed to go to work. And to this day, I still don't know how I made it up the stairs. But when I got into the living room, I collapsed onto the floor. And my mom said, "You're not going to work today." And I said, "I have to go to work because we didn't have sick leave, and if we had to have a doctor's note if we missed work." And so we kind of argued, but then when I tried to get up again and I couldn't get up, I realized that I'm not going anywhere. My mom just thinks I have the flu, and I'm not telling her anything different. So anyway, so she goes to work, and I pretty much stay at home and just miserable all day. I did call and make a doctor's appointment because I knew I didn't need a doctor's note, and he got me in the next day. I went into to see the doctor, and he said I had a case of food poisoning. I did not correct him of his notion. I thought it was kind of funny, as you do with when you are just not feeling quite right. I had just started seeing somebody at the Student Counseling Center. Actually, I'd been seeing somebody else, and I had just been transferred to somebody else. And he had encouraged me to come to this group therapy group. And I think that was my first night in the group. And I went, and I didn't say anything for the whole 2 hours until he asked me a question. And to this day, I don't remember the question. I just know that I disclosed everything that had happened within the last 72 hours. And so he dismissed the group. I have this reputation now about sometimes people call me Becky Downer because I can bring people to quite serious moments. Anyway, he stayed with me. And so I have to give you some geographic description.
Becky,
Yeah.
can I ask a question?
Yeah.
What year was this?
This is 1982 or 83.
And when you had your initial sort of episode where you were hospitalized and then discharged back to your family, was there any communication from the hospital to the student health service?
No. No.
Okay. So it sounds like you sort of bounced around with really inadequate attention because of lack of liaison and communication.
Yeah.
Which is, in 1983, probably what the situation was at the time.
Yeah.
The hope is it's a lot better now, but it's not nearly as good as it needs to be. So where are you now?
So anyway, I'll fast forward quite a bit, actually. They wound up taking me to the hospital that night again because I didn't have a place to go. I couldn't go. I was worried that if I went and stayed with my friends that my parents would get angry. And so I just had no alternative as a place to go and be safe. And I did actually have an active suicidal plan at the time. I planned to drive my car up to the reservoir and drive into the reservoir that night after I left. So I got admitted. I was hospitalized for 6 weeks, which is almost unheard of these days. And I refused to work with that other doctor that I had before. I just knew that that wasn't a good thing. So long story short, the counseling services really did save my life there. The therapist that I worked with really was instrumental in keeping me together through college. And I can never repay back the hours that I spent. And I was being seen 3 and 4 times a week, which is almost unheard of today. And yet that's what I needed. So that's kind of what brought me into the mental health field. And again, the other part of that is, yesterday I was talking a little bit about the self-injury. I was in therapy for 20 years before I ever talked to anybody about self-injury. That's how bad, I just knew more than anything to not talk about that because I knew I would be in big trouble if I did. But simultaneously, I also knew until I could talk about it, I would not get better. So we'll just stop there.
Thank you. Kay?
Kay Jamison. I'm a professor of psychiatry at Johns Hopkins Medical School. And my primary academic and personal interest is bipolar illness. I start with a thank you again to Ellen. Not an original thank you, but fabulous, fabulous woman. Done a lot for all of us, and thank you. Just one word about stigma. I really loathe the word stigma, so I just have to get that in. I mean, I think stigma stigmatizes as soon as you say the word stigma. There's an implication that there's somebody that needs to be stigmatized or is being stigmatized. I like discrimination. We're in a law school. I like the idea that the sort of legal implications of discrimination. In any event, that's just a bit of a sermon. I got interested in bipolar illness through my own experience, but not until pretty late in my life. When I was 17, I had my first psychotic break when I was in high school, senior in high school. And one of the panelists in the panel before us said something that I really responded to, which was, well, we oughtn't to leave white Anglos out of the consideration when we're talking about diversity. We should include them. And I thought, well, that's actually great because I work a lot with the Episcopal Church, and one of the things that anybody who's an Episcopalian will know is that if you're brought up, I think, in a pretty high, as it were, Protestant church, and I was also brought up in the military. My father was a pilot and a scientist. The things you really don't talk about are mental illness, and it doesn't make any difference if it runs throughout your family like wildfire. You don't inconvenience somebody, you don't bother them, and you just get on with it. Okay, so this is hugely difficult in terms of running your life if you kind of go psychotic as I did. It went on and on throughout college and graduate school, and then when I became an assistant professor at UCLA, the other university in the area, when I took a faculty appointment there as an assistant professor, I went flamingly psychotically manic and had no choice really but to get into treatment. It was very much a medical emergency. And at that, when I recovered, I got put on lithium, responded very well pretty quickly, fortunately. My interest became radically interested in mania and depression. And at that time, it was a long time ago, and that time there really wasn't that much known about the long-term course, but what was known was it wasn't very good. And the only treatment that was existing at that time was a very good one. It was the one I'm still on, which is lithium. But that was the only treatment. So if you didn't respond to lithium, you were just really out of luck. So I got very interested in bipolar illness and have studied it ever since. There's nothing like getting a disease to motivate you, I can assure you. It's really the most motivating thing that I know. After many years of running the mood disorders clinic, the affective disorders clinic at UCLA, I went to Hopkins, back to Washington, Baltimore, but I was from Washington. After several years on the faculty there, I decided I would write a book about my own experience and ran into all the issues of, what are going to happen to my hospital privileges, to my license, to my privacy, to, all of a sudden I knew I was going to have a diagnosis in my forehead that said you are a raving bat, as it were, to the world, and was going to be very convenient to put me in a pigeonhole and leave it there, as it were. I went to the chairman of my department at Hopkins, and who could not have been more supportive, and basically said this is exactly what we should be doing at Johns Hopkins. We should be at the front edge of trying to destigmatize these illnesses. And if anybody gives you any trouble, any of the house staff, any of the faculty, send them to me. He set me up for a lunch with the president of the hospital, and who said exactly the same thing. We have your back completely. And that made it was still difficult to do for a lot of reasons, including the response to it. But it made it a lot easier having a medical school that actually did what it talked about. In other words, instead of just sort of saying, well, of course we're against mental illness, they actually said, we will back you in your journeys here. And they did, and they have, and they've been tremendous. So I'm very lucky in that respect. I have spent a lot of times when I went on the book tour for my paperback version of my book, I asked my publisher, I said, I really don't want to go to one more book reading. I would really like to work with students. This is the age of risk is, college age. And I want to talk to students, and I want to hear their stories and see, what we can do. So I've spent the last many years trying to learn about that. And help.
Thank you. Let me just frame the set of questions we're going to try and address now by saying that it seems that there currently is a convergence of three different types of issues that really impact the area of providing sort of mental health care services to a student body in universities or any educational institution at this point in time. One is basically there is an enormous public health opportunity here, that being what we've learned about mental illness and what its sort of natural history is in terms of when it begins to manifest itself and begin to sort of produce symptoms. And that turns out to be during adolescence, or particularly late adolescence, mid to late adolescence, early adulthood, which makes high school and college, sort of right in this sweet spot. And so if one were taking a public health approach, this is the population to sort of address, and educational institutions like universities is the perfect place to do it. But second issue is universities are educational institutions. They're not necessarily healthcare institutions. And so how does the healthcare responsibility or opportunity sort of get integrated into that? And built into that are things that we don't like to think about, which have to do with risk management and liability and so forth and so on. And then the third thing is the personal issues pertaining to the students who are affected and their families. So these are privacy issues. This is sort of authority and responsibility issues. Who has the right to sort of provide treatment or to sort of propose diagnoses to try and influence what individuals do. We're seeing it played out in the national scene now with the Affordable Care Act, where it's being characterized not just an effort to reform our healthcare system, but as assault on our sort of personal liberties and civil rights. But in a similar way, universities, are faced with, what are the limits of our authority and what is the personal civil rights of the students and their families. So these three things are convergent now, and they produce both, a nexus of opportunity, but also a lot of tension. So I'm going to begin by asking maybe Brandon to start out by saying, so as a student who's gone through this experience, what, from a student's perspective, what do you think is sort of the biggest sort of obstacles or issues that could usefully be addressed to try and improve the way that mental health is really managed and supported in the context of college and higher education?
Sure. So the one that comes to mind initially is just stigma and discrimination. Sorry to use that term, but people understand it. So when I started to speak out about my condition, I started to tell friends, and it's kind of a long story about how I started to speak out publicly about it. But I can tell you later if you're interested. But it was very liberating. And all throughout college, I was hiding the diagnosis and my condition. And I didn't want to seek help. I didn't want to let anybody know that I was sick. So if we could create a culture in universities and high schools through education of students and faculty of what mental illness is, that it's a brain disease, that is basically a biological disorder, that it does not reflect on the character of the person who has it, and that everyone is essentially human, whether they have mental illness or not. That would go a long way, I believe, toward enabling students with mental illness to feel more comfortable in seeking care and just doing well in life because they're not so prone to withdraw socially from their friends and the people around them, and thus can maintain and establish stronger social support networks that can nourish them as they go forward.
Becky, you want to add your own experience or perspective on this?
Well, I think that we really need to talk about mental health issues like we talk about breakfast. I really, one of the things I would love to see changed is I would love to see the title of the abnormal psych course changed. Enough people have challenges with mental health issues, whether it's episodic or transitory or just one time, that if we could change that course and change some of the misinformation that's given in that course about the rarity or supposed rarity of these different conditions, and talk about that we have responses, and there's a wide range of responses to different situations in our life, and that there needs to be resources so that that's really easily accessible, that you don't have to go hunt and find resources for mental health problems, and that, so you had, so you just had you just broke up with your boyfriend or girlfriend or whatever, and you're feeling like this. Maybe you might want some support this way. Some ways that are just really easily accessible to people that doesn't make them feel like that they're weird, because they already feel like they're weird. And the way that we make people beg and ask for services just adds to that.
So education and really attitudinal differences would be key here. So Kay, let me pose what may be a difficult question to you to start. We talk about sort of mental health needs. Brandon sort of alluded to sort of a whole spectrum, because everybody is faced with certain challenges when they go to school, and it's exams, social relationships, being away from home, opportunity for recreational drugs and so forth. So there's problems that people have in living, and then there's problems that individuals who have some predisposition or constitutional vulnerability to a more recurrent or sustained mental disorder have. How do those get addressed by a university in this context?
I think with difficulty, and I think that the very confusion of our language, between mental health, mental illness, disorder, disease, illness, problems of living versus which everyone has. So anyone who's got schizophrenia or bipolar illness also has problems of living and then some. But then there are people who have only problems of living and no severe mental illness. I think the whole language system is insanely complicated, and I think that one of the things that probably ought to be done more is educating people long before they get sick, to have a much more proactive campaign, which means that, one of the things that one of my colleagues at Hopkins does, so she started a program in the Baltimore private and public schools, was to just go out and teach teachers, parents, and students the symptoms of depression. Say, this is what your kids are likely to get if they're going to get sick. These are the symptoms. It's really treatable. Much better to get treated earlier rather than later. So that when they do get depressed, it's not like they're coming up against this for the first time. The parents aren't coming up against it for the first time. We know that these are common illnesses. There's a huge science base to these disorders. It's not like we don't know anything. We know a lot. And we use that knowledge very sparingly when it comes to the public, and in particular the educational system. So I think way down the educational system, people ought to be getting much more information. And for sure, people who have schizophrenia or bipolar illness in their families, when they send their kids off to college, it would be really helpful to be able to tell those kids, look, we've got this illness in our family. The odds are you're not going to get it. But if you do, this is what it looks like. Here's a list of specialists in the area. And just deal with it rather than waiting for an emergency to come up, because we all know that people think less well in emergencies. So I just think some proactive.
Becky, did you want to add something?
Yeah, we also need people who are out and about and are successful with living with this. Too many people, there's still too many mental health practitioners who are telling people that these are very grave and serious conditions. Well, that may be true, and simultaneously, people with very grave and serious conditions are doing quite well and thriving. And that piece of the message does not get communicated enough. I can't tell you how many people I've talked to that are still being told today that there's no hope for them.
That's ridiculous. This attitude of therapeutic nihilism for mental illness is just it's just 19th century. Kent gave me these two volumes, which are relating to what Kay was saying about providing parents, students with basic information that they may not have become exposed to about mental hygiene, mental illness beforehand. Is that what these try to do, Kent?
Yeah, as I said yesterday, those are part of a strategy to educate the whole university community. And then there's a version which goes to families, which I only brought a few copies of, which is a collection of 50 articles from faculty, staff, students, and alums. And they're kind of love letters to the families of new students. But it's also a stealth volume about health and wellness. So salted throughout the volume are recommendations and reflections about all the things that students may encounter around their health while they're at Cornell. And we give that to the parents of every new student upon their arrival. And it's also online, and subsequently will be an electronic document instead of something that's in hard copy. But I think Cornell is a very interesting place. It has a strength and a weakness in its forbearance. Okay, I would argue that Cornell is a famously forbearant university. In other words, we don't require anything really. You don't even have to live on campus as a first-year student if you insist that you don't wish to. You're expected to, but you're not required to. And so on the negative side, it means we respect students' privacy in a way that interferes with our ability to notice and respond. And especially until we began this campaign, which we're calling Caring Community, a lot of people were so respectful of each other's privacy that, you could be floridly psychotic and walk around campus for a couple of years, and people just think, they're just going through a phase, no big deal. They may smell like, alcohol, tobacco, and firearms, but really it's okay. So that's the negative of it all. But on the other hand, it means when it comes to matters of reaching out to students and deciding whether or not they should be on campus, we're extremely forbearant. And so very few students are required to leave or leave the university for a time, and even fewer are separated permanently from the university. So that's a wonderful attribute of our university community, and it's been true from the very origins of the university. With regard to this caring community concept, for us, I think destigmatization, for lack of a better term, amounts to doing hundreds of different little things, okay? So it starts with the president talking to students by way of a video, speaking of his failures as a student, and also in reinforcing the idea that students really should reach out for help when they need it. For me, it's meeting with Casey Carr and a group of returning students who have been on leave of one sort or another, and talking to them about the year I took off from campus, and all the issues that affected me upon my return, so that I can share with them a personal story that helps them paint a picture of how they will return to campus. We train up all the RAs, the RHDs, likewise, to be really solicitous toward our students. So in the final analysis, without going into great length, we have all kinds of programs which have the same objective. It is to put a personal face, a caring face on all of the people who support our students. And it includes students as well. So EARS, for example, is another program of peer. You may want to talk about that because you run it.
You're my boss. You're doing good.
Okay. It's a group of students who are trained for 3 semesters to be good listeners. And in the process, it helps them themselves. And they themselves may have mental conditions of one sort or another, but it also is a peer support mechanism that goes a long way to connecting students who need assistance to students who are prepared to listen and support.
It sounds like from talking to you before and listening now that Cornell is really kind of in the vanguard of providing very proactive and extensive services. But let me just mention, I'm going to ask 2 other questions of some of the panelists, and I'm going to invite Steve to come up and select. Give me a couple of minutes yet for Steve to ask some questions that are come from the audience. But let me just sort of try and paint this in a different way. So we have a society in which mental illness has been historically kind of misunderstood or neglected. That's now becoming more and more aware, although it's not nearly as aware as is needed. It is comparable to non-mental disorders. And we have a university that's assuming more ownership and responsibility for this, however reluctantly. And some places like Cornell's exemplified have been really far-sighted and proactive in doing that. So let me just ask Raina and maybe Miriam. So do your university administrations, are they sort of supportive of your entreaties to do more as you see sort of this expanding need among your student bodies?
Yes. As we see from Cornell, everything starts from the top. At UC San Diego, we have had a phenomenal movement because student health and counseling and other units around what is called the cluster of student health and well-being have been moved from student affairs to health systems, which is in the health sciences, so that we can enjoy more resources of all sorts, from better assessment tools to better interventions also. Another thing that is very important is to focus on the fact that in the same way that we talk about beliefs and assumptions can lead to social discrimination, the same way would happen with mental disorders. And we have to look at it, if we don't want to use the stigma. Another concept that I like, it is about social justice, it's about social inclusion. And this one is even more important because we know that if these mental disorders appear during the college time, then we know by a fact that the earlier the treatment, the most aggressive, the most comprehensive, the most coordinated, that it is, the better results. And with that, we operate as a system in such a way that we have funds that allow for the training of faculty, staff, students. We rely on peers, by the way, because I love it when it is a roommate, it's a friend, and we have seen it here from our many stories that it was somebody who truly cared, who held a friend's hand and brought them in trust. And that's something that as a director is very important to me, that in trust this friend brings this precious life that they value so much to receive the help that they need. And having the resources, having that capacity is very vital. So we have to be very strong from within, have strong links with the whole system. A new concept that we have now is called care managers or case manager, whatever word you want to use. And these are those that help us monitor where is the student, what help is needed. Because we know that if somebody misses one link, misses one step, is going to be a major consequence for our student. And we are paying attention to something that is very important, which is the Title II change. Before, there was something that if somebody was a direct threat, the universities could dismiss them until there was due process for that student. Now, for the current times, it used to be for suicidal behavior, and it used to be for threat to others. And at the current time, under this change of Title II that has happened already for a few years, then the administration has to be very creative and very caring on how to manage the students.
All right, so I can't resist the opportunity to put you on the spot, Reina. So I know you're from San Diego. James Holmes, who unfortunately perpetrated that horrible crime in Aurora, Colorado, is from San Diego. What if he had gone to UCSD instead of University of Colorado? What would have happened?
I appreciate that question. I do not know the details of what went on. And here's one example where as you know, the psychotherapies, as healers, confidentiality is at the peak. It's the main tool that we have, because we have been hearing over and over again that I knew that if I talk about that, this would happen, and the person shuts down. So if we don't have that confidentiality, we have lost a lot. Nonetheless, we have our laws and regulations, and we know that if somebody presents a reasonable, immediate threat to self or others, then we can breach that confidentiality. And what we know is that this student, that went to high school with my nephew, by the way, he had been in treatment. But I do not know the level of that disclosure, because in California we have something called Tarasov. Mm-hmm. Under Tarasov, if somebody threatens and identifies an intended victim, then the mental health professional is mandated to report it to the intended victims and to the police also. So unfortunately, there is a space that I do not know about the communication between the graduate student and the psychiatrist to proceed from there.
Miriam,
And I think that many colleges and universities are embracing how we support students and really thinking about it holistically. Pomona, as I said, has a population of 1,600 students. We also hand out, and I brought some examples of just folders that we give to every faculty and staff member. We believe very strongly in preparation in terms of training for most student leaders, many student leaders, so I would say probably half the student population gets trained every year on supporting students in distress, identifying students in distress. We have a very strong tradition of peer mentoring groups. We train our faculty, we train our staff. We also have many collaborations. So we have, one of the things from all these different incidents is making sure that the counseling center, the residential life, the deans, the faculty are all talking. We have standing meetings. We have ad hoc teams when need be. We also, and I think this is very important for colleges and universities, believe in flexibility. So what are we trying to achieve? We're actually trying to achieve the success for the student and the care for the student. You know, kind of remembering that goal and being commonsensical. So this is my 7th year at Pomona. We haven't had an involuntary medical leave for a student. It's really working with students and with families. Families are partners in this and working with students. I think there was whether in this panel or beforehand, really talking about making sure the student feels empowered in what can be very distressing situations as well. So I don't think Pomona's alone. I think Cornell's doing a great job. It makes a difference whether you're at a small or large universities. We also have a 24/7 dean on call system. I mean, in some ways, we're at an institution where so many people are calling. You know, if someone doesn't go to a class, you may hear from a faculty member. So for myself, I think what's important is making sure, despite when it's a small community, do we have systems in place, right? Are structures in place? Because you can always have well-intentioned people, but making sure that there are structures.
Yeah, well, the contrast between how many students in UCSD?
30,000.
30,000. How many at Cornell?
22.
Yeah,
Right.
so, I mean, these are like very different situations. And as we were talking before, one of the things that's really apparent is that there's no standard, sort of uniform standard of care or uniform sort of system of providing care that exists, and it's something that would be very, very desirable. I'm going to raise a controversial issue and address it initially, at least, to Jennifer, which is, so if universities, by dint of having the population of interest and the opportunity to maximize their period of higher education, which is, as Miriam put it earlier, sort of maximizes their growth in the life of the mind, which addresses both just helping them through what's a challenging process as well as ministering to what might be the onset of a mental illness. That's a pretty broad spectrum. I mean, in medicine, I'm trained in medicine, that's called primary care. You deal with everybody just to keep them healthy, as well as if they get cancer or heart disease or diabetes. So that's a big, so how do you do that for 30,000 people? And do universities want to do that? Now, what it does is mean that there's going to be competition for what are the specific, what are your goals and what aspects of this task do you address? And Jennifer was somebody who had involvement with the legislation, Proposition 63.
Oh, I was not directly involved in the passing of Prop 63, but after our son turned 18, we're actually taxpayers into Prop 63. It's a special tax that, since inception 10 years ago, has generated, specifically to California only, $11 billion. And the spirit of the law was written in such that it was supposed to, certain percentages were supposed to be earmarked for certain programs covering the entire variety of needs, from homelessness and no insight to peer services of people who could advocate for themselves and navigate the system. So I'm involved now on after 2 years because we've specific to California, the $23 million of the money, it directly goes back to commissioners who are on the Oversight Commission. So there's some real concerns with accountability and oversight. We've had to push for an audit. Audits are inconclusive. So there's money, but
so this was a grassroots initiative that was.
It was co-authored by Rose King and Steinberg and a few others.
It was to set aside some tax revenue for the purpose of mental health care broadly described or defined?
Well, no, it was very specific. It was a 1% tax on anyone who has the income of $1 million or more within California, and then it's divvied up between each county behavioral health department depending upon how many millionaires you have in the county. And so since inception, we've generated $11 billion. So if you want to know where the funding can come from within California, there's absolutely no excuses for saying there's lack of funding for excellent programs within colleges across California.
But the concerns that have been expressed or that you may have to do with how those funds have been put to use.
The spirit in which the law was written is not the
final
outcome.
And what specifically is the issue, is the concern?
Specifically is that there's 20% that was supposed to go towards more treatment-based approaches, not just prevention and intervention. Because you can only prevent so much. You can only intervene with somebody who is lucid enough to accept your interventions. My biggest concern is, what do we do for those who lack insight? What do we do for those who are going to die in the street tonight without care? Like my son, who will continue to behave the way he behaves, regardless of what interventions or prevention program you want to offer.
So I'm going to put words in your mouth. So on one side, there's sort of an emphasis and an interest in supporting wellness and prevention, and on the other side, it's treatment for people who have, in the jargon, is referred to as sort of chronic and persistent mental illnesses.
If you would ask me what I think would fix it, I think the system needs to be turned upside down. I think it should be a triage system of medical care. And when we start there, we deal with the sickest individuals first, those who are chronic, and go up. And not just medically, it needs to be a balance. Wellness and holistic models and recovery models are so important when paired with real evidence-based approaches that we know save lives. And in California, we're not seeing any evidence-based approaches with the $11 billion.
Brandon?
Okay. I'm not sure if the Prop 63 funds fund this particular program, but there are programs that are testing evidence-based approaches, creating evidence for the approaches to work in prevention.
Not for the involuntary. There isn't one penny that has been spent for involuntary care, and that's the misunderstanding.
Okay, no, there should be money spent for that too. Yeah. I'm just stating that
there's some
prevention,
great programs. They've done some wonderful things, and they forgot a population of people.
I would just point out that what happens is when an area of need and healthcare disparity is given short shrift, it's the constituencies that have been sort of neglected that end up having to fight among each other for really the inadequate resources. So I think we need to have that discussion, but nobody should feel that this is something we've created ourselves. It's something that we're just we have to deal with. Becky?
So I want to take kind of a different approach to this, and that is in terms of engagement with people that have that are really struggling. Because I think that it's the discrimination within the mental health profession that happens, that people stop engaging with people. The decision that because somebody's in jail means that they withdrew from treatment is just crap. And somebody needs to say that and say that the emperor's wearing no clothes. People who are acutely psychotic can and do respond to relationship. And we have to say that we have to keep trying. If you go out and you just bring them a sandwich or something to say that you want to spend time with them, you want to listen to them, you're concerned about them. I get so many calls in the role that I do as an advocate. That's another whole life story thing. But I got into advocacy because I couldn't advocate for myself. And I thought if I tried doing it for other people that I would eventually learn how to do it. And I have so many parents and family members tell me that the mental health professional said that there's nothing they can do, and that they can't make a phone call, they can't go to the person's place and find out why they're not showing up, that they can't do anything, that there's no, and I'm just like, Who says can't? Figure out what's going on in the relationship there. We have to figure out new ways to engage with people, or just try and engage with people and keep trying. Don't give up.
I think we're going to invite Steve to come up and select some of the questions to ask of the panel from the audience.
What I'm going to do is to read the questions. Some are directed to particular individuals, some are to the panel as a whole. So, Jeff, I'm going to read the questions, then I'll take the cards to you, so you'll have them. And then I'm going to ask for the cards back so we can have all the questions. Okay, the media often makes an equation between violence and mental illness, which reinforces much of the public stereotype about persons living with a mental illness. You can cite the studies over and over about how a person with a mental illness is more likely to be a victim of violence than a perpetrator, but it seems to make little difference in the public's perception. What does the panel recommend be done to address this stigmatizing, and I'm going to add the word discriminatory perception? Okay. Second question.
Go ahead. Why don't we just respond to one at a time?
Okay.
You can stay up there, though. Okay. Brandon?
Sure. As Timothy mentioned yesterday, the most effective approach scientifically has been found to fight stigma is to have social contact between people who have mental illness and people who don't. A great way to, on a large scale, spread information about personal information about people who have mental illness and thus forge a vicarious connection, or at least an understanding what they're going through, is perhaps online. There are organizations, one called Bring Change to Mind. It's Glenn Close's organization. I've participated in the PSA, which launched it and then helped the website, develop the website for it. But it, like some other organizations' websites, offers a share your story feature where people who have mental illness can actually share their stories on the website, similar to the monologue, the webcast monologue that Danny was talking about on his USC Free Minds website. But these are just in text. So I think that the more people who do speak out, like you said, Becky, about who are successful in doing well with mental illness, as examples of people with mental illness who are not violent, who are good, obviously stable people, will help promote a greater understanding that people with mental illness are not more likely to be violent than other people.
Okay.
But I think we have to also be honest about the fact that it's true that people with mental illness are more likely to be victims, for sure. But it's also true that there is an increased rate of violence, say, for example, with mania. 50% of acute manic episodes are characterized by at least one act of physical violence. So my feeling is if you really want to destigmatize something, you have to start with the truth. And you have to say, this is the way it is, that these illnesses are treatable. And therefore, it is really beholden to society to invest the money in research, because when people are treated, they aren't violent. But if they're not treated, I don't think we do ourselves any favor by saying something that the scientific literature doesn't back. I think the scientific literature would say, yes, there is an increase. It's not a huge increase, but it's definitely an increase. And anybody that's a family member, or many people who are family members, will know this. And for sure, the crime statistics will bear it out. But I think what's important is to say that we're all in this together. And if we want to decrease violence in society, we need to do some things about access to guns with people who have mental illness, mainly for prevention of suicide, but for other reasons as well, but primarily for prevention of suicide. And we've got to really invest in research that will allow people to have earlier diagnosis, better diagnosis, more specific diagnosis, better treatments, because that's where the discrimination really comes in, is in the research funding. And I think that is a huge problem. And I think that one of the things we forget as people who have mental illness is we are first and foremost voters. And, we have a political voice. And if you look where people have been effective in breast cancer and AIDS, They've been affected because they've gone out and voted and said, we're not going to tolerate this anymore. And we have a much broader base of people, much, much, much broader base. And we need to really ask politicians, so are you backing this bill? Are you backing an increased amount of research monies for NIH? You know, what are you doing? And I think we haven't tended to do that.
Let me just, Jennifer?
Just real briefly. Real briefly, I worked Alzheimer's care years ago. I did caregiving and hospice care. And so the first thing that came to mind with that question was, I would say, forget saying mental illness and violence and say brain anomaly and symptoms that can lead to aggression that can lead to violence. Because we had patients with Alzheimer's that could be aggressive, that could be violent. We have symptoms of people who have severe Down syndrome. They can become aggressive. That can turn into violence, you know, on and on and on. But I think society can swallow and understand and somehow make sense in their own mind that someone with all these other brain disorders, Alzheimer's, dementia, you know, autism, their violence is somehow not their choice. But somebody with a mental illness or psychiatric component, it somehow is a choice. And it's such a huge disconnect in the education. I don't know how to just educate people on that. Maybe if we take the mental illness term out and call everything a brain anomaly, brain disorder, whatever, it's all, you know, it's in the DSM under brain illness. That might help with the stigma part because it's a little bit of a level playing ground.
Yeah, I think the terminology is certainly an issue, but that for the past 9 years there have been approximately 30 of these civilian massacres. The rate of violence of mentally ill people, of all violent crime, is 4%. If you look at intra-family crime, it rises to about 8 or 9%. But if you look at these civilian massacres, it's over 50%. But in these civilian massacres, all of the individuals virtually have been untreated. So when somebody says is there associated with violence, it's these media publicized that really, you know, galvanize public opinion that have created this sort of association with mental illness and violence. But the reality is this is the tip of the iceberg because of lack of treatment. Sorry, go ahead.
Another question. Until now, college counseling centers have often been able to provide more services than are available to those covered by private insurance or public funding. How can efforts to move these issues forward thrive in the current environment of controlling the cost of higher education?
Wow, that's a tough question. That's a good. Kent, why don't you address this?
I can tell you that what at Cornell we are doing is as of next year, we're imposing a health fee that all students, again, I said famously forbearance, so there are exceptions, all students will be expected to pay, okay? And what that does is it reduces the cost of insurance to individuals because you have a larger pool. So that's one step we've taken to try to create a broader set of services at a more reasonable cost to families of our students.
I would say, can I say just a couple of things? One is we've made the argument that investment in mental health resources and physical health resources is actually really important for the return on investment for the colleges and universities. So it's again, what's the goal? It's student success, student graduation, student thriving. Well, putting support in mental and physical health resources is really important. From my perspective, is also requiring insurance. We went from having maybe 9 to 10% of the students on the college health insurance to now over 30%. And then also looking at different revenue streams and some different business models for our student health services and for our counseling. I think you have to be creative and you have to look at utilizing the community, but also no doubt investing more resources in student health and counseling.
Becky, did you want to add something?
I was going to say, Portland State requires all students that carry 5 credit hours or more to purchase their college insurance, and they increase the quality of the insurance. It still lacks in a number of different ways, but they did increase the quality of the insurance plan that they bought, and that helps with some of the costs for the college counseling services.
Raina?
Yes, and one thing that I want to add then, for instance, in the UC system, health insurance is mandatory, and for students who cannot afford it, it gets adjusted through their financial aid package. But that is not enough because a community has to have a strong referral resources because we cannot absorb all the needs, especially for students that fall out of our scope of services, which would be those needing long-term, intensive, complex treatment. So what we do is that we go out into the community and we carve out connections so that we can refer them out.
Okay. And there are a number of questions. I'm going to start with the ones that focus specifically on educational institutions to get to those. What are some structural changes that we can make to educational programs to reduce the incidence of mental illness? For example, are there any statistical studies on how grading systems such as normalized curves in law schools affect mental health?
PTSD from law school.
Nice try.
I was watching, I don't know how it happened. I was flipping through the channels the other day, and that movie Paper Chase was on. And my older son went to law school. He's a lawyer, and he came in. What are you watching? I saw he watched this. He says, "Dad, that is just so antiquated. It doesn't happen, but maybe it does still."
Can I just say a couple of words? I do think that there's a transformation now starting to happen, but still a long way to go around universal design. And it also affects students with disabilities to really think from everything from time tests, actually asking, faculty having to justify why they need a time test rather than students having to show that they need time and a half or double time or distraction-reduced environments. So I think there's a whole way that we as educational institutions have to look at how we're delivering the content, to what extent is it fundamental to the content, and changing it that can help students with a whole range of disabilities and other issues as they engage in the classroom. So that's just one example.
And I would add that I do feel that the academic stressors are sort of the elephant in the room. That at our university, which has 7 undergraduate colleges, students take courses in all the colleges, and there's very little coordination. So some faculty just relish the idea that there have to be 30 books that you're going to read. And if you take that course along with another ambitious faculty teaching an ambitious course, you can be in big trouble unless you're a very bright student. So there's a lot of work to do, I think, on that side of the house to make sure that there's better coordination of the coursework, and that the faculty are not so focused on the high-achieving students at the expense of the students who are just like the rest of us.
It's sort of connected to that is, we were at a Council of Mental Health across the campus, and faculty were talking about what they required in each of their classes, and you really saw these light bulb moments like, whoa, looking at each other. But one faculty member made the case that faculty are deeply challenged when students have to ask for, after the course has begun, accommodation or catch-up or rescheduling. And she made the argument, it's in the faculty's best interest to schedule in flexibility on the front end that will benefit all your students, but especially those that are going to need your assistance. And guess what? Your life gets better as a faculty member. I thought that was pretty darn persuasive, and I saw a few faculty going, yeah, it's awful when you have 200 kids and all of a sudden you have 15 students writing you saying, I can't take the exam.
And the faculty get involved when they are also affected by these problems. Okay, so there were a handful of faculty at Cornell whose children wound up on the autism spectrum. And guess what they did? They mobilized. So now we have a group of faculty who are working with Student Disability Services to support a program that will help students on that spectrum at Cornell.
Okay. Question about terminology. How should we say someone has a mental illness? I have begun to use words like suffer, experiences, but I am often questioning what comes out of my mouth because I do not want to offend someone. At the same time, I want people to understand the degree of severity and the treatability, the degree of severity and realness of mental illness carries. Could we rename mental illness?
Brandon?
I think too much attention is paid to terminology. For example, personally, I don't care what you call whatever I've got. It's the spirit in which you say what you say that matters, to me anyway, and I think to many people. I think that, that said, I do think that perhaps calling a mental illness a brain disease or a brain disorder, as you've said, can focus the attention on the fact that it is a biological disorder and that perhaps allow more funding to go to the research which can hopefully find cures for it and or preventions in the near future. So my advice would be, if you want to call it anything, call it a brain disease or a brain disorder, but it doesn't matter that much. I think the attention needs to be on how to treat and cure these diseases better rather than what to call them.
Becky?
So I really don't like the term brain disorder. My issues with my mental health issues, I talk about mental health issues and mental health challenges, are more complex than that, and it hasn't helped me. I also think there's an issue of talking about people's experiencing and attributing their quote unquote suffering. I really am the only one that gets to say whether or not I'm suffering. Yeah. And I really don't care what you think about whatever it is that I'm experiencing in terms of my suffering. I want you to be empathic with me, but I don't really want you to ascribe that I'm suffering, because in fact I may not. I may be having a hard time, but I don't know about suffering, because our life is hard, regardless of whether you have a mental health issue or not. And what is suffering to one person is not necessarily suffering to another. Also, the other piece that hardly ever gets talked about is the gifts that people with mental health issues get from the struggles that they have. And I mean, I certainly don't want to go back and repeat any part of my life, but I wouldn't trade where I'm at today for another experience. I really like where I'm at today, even with when I'm struggling and the challenges I still face every day. But that said, terminology, I still cringe when I hear some terminology. The serious persistent mental illness is one that makes me really cringe. And having one of those diagnoses that falls under that category, but I can deal with cringing.
I'd just like to make a couple of comments about this. So I think, as Brandon was saying, nobody's totally happy with the terminology. The Japanese even changed their name for schizophrenia to the Japanese equivalent of sensory integration disorder. And Korea followed suit and did something similar. I don't speak Korean, so I don't know what it translates into, but it isn't schizophrenia anymore. But on one hand, when you talk about brain disease was an effort for people that said, look, I'm tired of having mental illnesses sort of marginalized and said to be, oh, it's all in your head, and just suck it up and get over it. And so brain disorder sounded much more compelling. And in fact, with some conditions, schizophrenia, bipolar disorder, depression, you can find abnormalities or evidence in the brain which is associated with this illness, which would legitimize that. On the other hand, you have conditions like anxiety disorders or late premenstrual dysphoric disorder or hoarding, where there's no evidence for any real brain abnormalities. I mean, we think there could be, but you can't say there are for real. So, it's not really clear that one or the other is totally sort of, but then we have this sort of need to euphemize stuff. You know, on one hand, we make brain disorders to say, okay, it's really something real. On the other hand, we're tiptoeing around. So something that's, I don't pretend to have a position about this, but is endemic to our field. I call the people that I see clinically, and like Brandon, who's very open about, and Becky, very open, I call them patients. And I don't know, Raina, what you call, or Miriam, what
My
you?
clients.
They're clients, okay? Now, when I go to see my dentist or my ophthalmologist, I'm a patient. When I go to see my lawyer or my insurance agent, I'm a client. So
That's a role. And our diseases or our disorders or whatever the hell we want to call them are not roles in life. And I think there's a big difference.
well, so a patient is a role or a client is a role?
Yeah, it's a role. You are a client. A client or a patient is a role. It's not who you are. It's not your label. It's not that. It's just a role. It's like being a mother, a sister, a brother, a father, an uncle. But it is not. You're not your disorder. And I think when we talk about these, I think that's some of the challenges we encounter.
Okay. Well, again, I don't want to sound like I'm sort of perseverating on this, but if you have diabetes,
I do.
are you a diabetic?
I don't refer to that way, but a lot of people do.
Okay, but there's not any sort of great sort of issue that's in the endocrinology field about sort of the reference to it.
But they don't have a history of locking people up with diabetes, where they do with people with mental health issues.
Fair enough.
We have a blood test for diabetes too, right? Like, is there when you diagnose mental health issues, do you do any kind of neuroscience scan or blood test?
Right now, there's.
I mean, just admit we don't understand it. That's all I want you to say. Like, say we don't really understand this stuff.
Brandon?
Sure.
Yeah,
okay, no, can I just respond? Thank you. So, the North American Prodrome Longitudinal Study, or NAPLES, is developing biomarkers for oncoming psychosis, the prodrome for psychosis, which also worked for psychosis. One of these is salivary cortisol, high levels of cortisol at the baseline assessment when someone first comes in for assessment. There are others being developed that look at the startle response when somebody has a loud noise played in a headset, how fast that happens, how.
That's basic science research.
Listen. Please, you made your point. We're going to answer, but you're interrupting the proceedings.
American Psychiatric Association. Why don't you say we don't understand what these things are?
Listen, sir. You are socially inappropriate, and you also don't know what you're talking about. You're advancing a completely ignorant and irresponsible point of view. Let me give you an example. When AIDS was first developed, so I was in training in late 1970s. People were coming into the emergency rooms with these opportunistic infections, Kaposi's sarcoma, pneumocystis carinii. No idea what was happening. There was no diagnosis for it. We only diagnosed it by the symptoms they had, which were complications. After some years of research, it was identified that they had kind of a devastation of their white blood cell production, but from unknown causes. After some more years of research, there was the identification of a virus, the immune deficiency virus. It occurred in this accelerated fashion. Why? Because there was such aggressive advocacy that the federal government poured money into studying this, like it was the scourge of humanity, even though it only affected some specific high-risk populations. When I trained, nobody ever talked about autism. Autism was part of mental retardation. Then some famous people's children and grandchildren developed, and it became a public health issue and the disease du jour. But how did you diagnose this? You couldn't, there was no biologic measure, no laboratory test. It was when somebody grew up, as the child matured, they didn't communicate, they didn't emotionally bond, they didn't act socially appropriate. Without any knowledge of what was causing this, this was attributed to their upbringing. And women, mothers, were called refrigerator mothers. It was ridiculous. But once it became a hot disease, lobbying, powerful people, the government poured a lot of money into it. And now there are biologic tests for it. So you can examine from the age of 6 months to 2 years, you can see cortical hypertrophy, overgrowth in the cortex on MRIs of these kids that can diagnose it before their behavior is differentiated enough to be able to, and their white matter. So here's a diagnostic measure, Alzheimer's disease. When I was training, Alzheimer's disease was just senility, it was aging. The only way you knew was because somebody began to lose their memory. There was no diagnostic test for it. You didn't know if somebody had cerebrovascular dementia, Alzheimer's dementia, Pick's disease, frontal temporal dementia. Now they have a radioligand that binds to amyloid that has been approved by the FDA and is used as a diagnostic test. That is what Brandon is referring to, which is being developed for schizophrenia. The reason why these diseases have been so unknowable and so discriminated against historically is because there was no sort of real basis for sort of understanding them. No clear lesions, no clear pathology. Why? Everyone blames, us for not having been smart enough or worked hard enough or whatever. The reality is that these are illnesses or disorders or traumas that occur in the brain. The brain is not just a little more complicated, not even twice as much more complicated. The brain is exponentially more complicated than any other organ of the body. If you look at the lungs, the liver, the kidneys, and you put them under a biopsy, put it under a microscope, every part of it looks exactly the same. They perform a single function. The brain has 100 billion neurons, 30 trillion connections. Every part of the brain is different than every other part of the brain. And neurology has picked off the easy things, the strokes, the tumors, the Parkinson's disease, that are very simple. The illnesses that are dealt with in mental health care and the things that happen when kids go to school and incur the challenges that they do are affecting the most highly evolved functions in the human species in all of the animal kingdom. So these are far more complex. They are far more subtle than the lesions that happen when you have a penetrating brain injury or you have a stroke or you have a tumor. And that's why it's taken so long. And because it's been so complicated, all of these other misrepresentations and distortions have been heaped upon it. And we, and particularly the people who have experienced these most severe forms, have suffered from it. But it's changing. It's changing. And happily, because youth are most vulnerable to these things, colleges are getting out in front of it. And so that's a good thing, and that's why we're all here today.
Well, Jeff, just to pick up on that, this comment is just remarking that over the past 2 days, this speaker is saying that as this speaker has listened, they have heard an enormous amount in the words pain and aching in the conversations that we have held. And these are just very difficult and challenging conversations to have, and that we are all struggling with how best to move forward here.
Okay.
This is a question for Jennifer Hoff. Earlier panels have discussed the criminalization of mental illness. What role do you believe that stigma/discrimination played in what happened to your son?
Okay, so where do we begin? My take on the terminology to me is of the utmost importance because it precedes everything we do. And if we're not reading, if we all don't know that this is a water bottle and we all know what the water bottle does, and we could be talking about 10 different things. So from my perspective, terminology is key for me. I don't necessarily have to be involved in telling you what you think about yourself, but I need to know we're talking about the same things. And so along those lines, the discrimination against people with psychiatric, biological brain illnesses is so pervasive in America. It's not epidemic, it's endemic. It permeates every attitude and belief people have when they're interacting with each other on a social level, whether it's children in school, they behave a certain way. The psychiatric issues come out, their symptoms present behaviorally. So it's always a challenge for a teacher or for a corrections person or a staff member in a facility to take that behavior and not just react to it with punishment, which is kind of where our society likes to go. So I think that the criminalization of the mentally ill, we're criminalizing people who cannot choose differently based upon a biological brain disease. And when my son was a child, under the age of 18, child in the eyes of the law, he was a patient with a team of psychologists, team of special education specialists. About 15 different people with doctorate or master's degrees were involved in my child's medical care and his stabilization. And when he aged into his civil rights, he became a client of mental health services. And we were flabbergasted. We didn't understand that the medical part disappears when your civil rights kick in. And if we want to talk about the elephant in the room and the tangled knot of how we get here, last year when I had a few questions, there was a criminalization of the mentally ill conference that Ellen Sachs hosted, and the questions I had were, how do we take this data and translate it into decriminalization? And the answers I received from 3 different people with doctorate degrees was, well, that's the elephant in the room. We can't possibly go there. And I don't see it that way. I don't see an elephant. I see my son who's sick, and I see him now in an environment where he's among his peers. He's in an institution criminalized when he could and should be in a medical facility stabilized. And nobody wants to talk about how we got here because there's people who want to blame and point fingers. And I'm not interested in finger pointing, but I am interested in looking to the past to see how we untangle the knot so we don't repeat it again. Did that answer your question? I'm sorry. I tend to go off that way and that way. And the problem with being a client, and this is from the mother's perspective, he was a sick, disabled child. He was on SSI. So in all respects, he's a disabled child. To call him a client implies that he has choice. I choose to be a client of an attorney. I choose to be a client or participant in something in life. I don't choose to have the psychiatric issues that I have. I don't choose to have them. I don't. I don't want them. I have them. I have to manage them to advocate for other people. But to say client, from my perspective, and many families who have children that have aged into adulthood, it implies choice, and that precipitates stigma. Because if it's a choice, you're choosing to behave that way, it's a choice. In my mind, I actually think that it kind of perpetuates the stigma, where if you're a patient, it's not your fault. It helps reduce stigma, but that's just from our vantage point.
Well, it was interesting because I've had this discussion with the advocacy groups that I've been very involved with, and I much prefer being called a patient. I work in a situation in medical school where people are patients, not clients. And the advocacy group that I was talking about is the largest one, felt very strongly about the client, that it empowered and did all this other things. But they finally actually polled their membership and asked people what they wanted to be called. And the overwhelming majority of them wanted to be called patients. I mean, it was a very interesting thing. It was people making assumptions. I personally believe, like you do, that people have a right to call themselves something they want. We've earned it. I mean, I've earned the right to be called whatever I want. I've been through the psychosis. I've been through all the consequences and traumas that this illness can bring. I don't want anybody telling me what I want to call myself. I believe that about patients and clients. There are a lot of circumstances. People have strong feelings about it. That's great. But I think that it should be acknowledged that actually when people were asked about what they preferred to be called, the overwhelming majority actually chose to be called patients. So these are people with bipolar illness and severe depression. You know, not everybody did, but.
Well, it goes toward medicalization.
The funding
of these
too.
illnesses.
The funding for clients doesn't exist. Funding for patients and for illnesses does. So it's an interesting. The people who decided to put together I remember getting an internal page from the county behavioral health department from his case manager, who told us we had to support his housing choice. He was homeless and wanted to live on the streets of the Civic Center, and we were being insisted upon to support our son's choice of housing, like he's choosing anything. So it's a one-dimensional approach, and it needs to be a multi-dimensional approach.
See, that was the piece I was talking about earlier. Very few people choose to be homeless. Mm-hmm. We don't have supports and services that actually work with where people are at. I mean, try as you might, I can't make you be where you're not. And until I figure out a way to engage with you and you make some decisions that you might want to do something different, I have to keep working with where you're at. And our system continually, for people who are hard to serve and hard to work with, they make it about the person. You never hear about the program that failed, but you always hear about the individuals that fail. We have those people who are in jail that are being served by the homeless system. We even have people who fail in the homeless system, and nobody wants to work with those folks. Nobody.
Yeah, I mean, I'm happy to say that I think for far too long, doctors in general and psychiatrists in particular, didn't get it. And now, I don't know if you read this, Becky, but one of the things I do in my role with the AP is I write an article for each biweekly. And the last one we wrote was with a colleague of mine, Lisa Dixon, on patient-centered care and shared decision-making, which really introduces, it shifts the center of gravity in terms of how clinicians work with people. And so that's really something that I think is really a big improvement, and it's not sort of fully realized, but it's underway. Reina?
I just wanted to make a clarification of why where I work we use the word client. We are a counseling center. We are not a clinic. In our counseling center, and there is a difference between a clinic. If I have worked in clinics and then they are my patients. But in a counseling center, I work with the students that are going through a phase of life, who are going through developmental stages. And on top of that, we have to do outreach, we have to do consultations, we have to do mental health promotions, prevention work, and that word is very key. But if I were working in a clinic, I will call my students that came to my clinic my patients also.
We have two questions, one directed to Dr. Lieberman, the other to Dr. Jameson. I'll start, Dr. Jameson, with you first. It says, you mentioned that not much was known about long-term outcomes for psychotic illnesses. Tom Insel summarized the findings on outcomes and antipsychotics on his NIMH blog. He points out that medication often is correlated with poorer outcomes in long-term studies. This is consistent with most longitudinal studies of over 10 years. Can you respond to this in terms of your perspective on long-term outcomes? So the question
Sure.
is your...
Let me just clarify a couple of things. First of all, I didn't say that. I said that when I first got ill and diagnosed, not much was known about the prognosis. I think a lot is known about the prognosis of both bipolar illness and schizophrenia. I am not sure that that's what Dr. Insel said. I think he said that there were some patients who had schizophrenia who could do without medication and do well. I don't think he said that the long-term outcome was better without it. As a matter of fact, I know he didn't say that. And the illness that I study and treat is very clear that it's a progressive illness, and that's been known for a very long time. That it tends, if it's left untreated, it tends to get more frequent in its course, and the episodes become more severe, and it becomes harder to treat. So there's actually quite a bit known that the prognosis is quite bad if you aren't treated. The prognosis, if you are treated well, I mean, you get good treatment, is that the prognosis is really pretty good. There's a lot of variability, but that the prognosis is certainly hugely different if you're treated and medically with medication than with not. And these are not 10-year studies. I mean, lithium has been used for manic depressive illness since 1949. So these studies are huge studies, and they go for more than 50 years now.
Dr. Lieberman, a comment was made on a panel yesterday to the effect that 1/3 of people with schizophrenia and bipolar disorder can come off their medications and function normally. Can you comment on this statement? Is that correct?
Well, I mean, I think all treatment has to be individualized. There are, people who achieve a good level of response in terms of symptom remission, recovery of function with medication, and either because of side effects or because of a preference to see if they can sort of sustain, their remission, want to discontinue medication, try and do so. In my experience, if somebody has well-diagnosed or definitively diagnosed bipolar disorder or schizophrenia, the likelihood of them having a recurrence, not necessarily immediately, but at some point in time, is extremely high. In fact, there's very, very few people who, if they have a definitive diagnosis, meaning a diagnosis with a very high confidence level, can sort of remain illness-free for the rest of their life without sustained medication. And by medication, first of all, medication alone isn't sufficient. In the vast majority of cases, it's one part of treatment, which may include psychotherapy and may include some type of cognitive rehabilitation or social skills rehabilitation or cognitive remediation or case management. But the medication can be minimal. It can be really the lowest effective maintenance dose and at a level that minimizes any side effects. And what happens many times is the medication is instituted when somebody is acutely symptomatic, and it achieves at some point a therapeutic response, and it's maintained at that level instead of being adjusted. But at the same time, you can also go too low. And Brandon was sharing with us his experience. Do you want to comment on that, Brandon?
Sure. So after I graduated from college and had worked for a few years, I decided I wanted to go to graduate school to get a master's degree in engineering. And I applied and got into a couple of good schools. And I realized that if I was going to work in graduate school and study there and do well, I would probably need to sleep less than I was sleeping every night, taking clozapine, which is what I was taking at the time. I forget the exact dose, but I think it was something like 300 milligrams per day. And I slept about 9 hours per night on that dose. And so at that point, I decided I wanted to reduce my clozapine dose. I did reduce it on my own initiative down to about 150 milligrams. I let my doctor know I was doing this eventually, and he said, "Oh, you probably shouldn't do that." But he agreed to let me continue because, he agreed that he approved eventually because I was doing okay on that lower dose. But when it got down to 150 milligrams, I had a terrible resurgence of symptoms. Terrible pains in my head, delusions about why the pains were occurring, and I had to stop working, and I had to resign from my job. I had to go back into the hospital, and I didn't restabilize for 2 years. Even increasing the clozapine dose again didn't help me at that point. I had to change to a different antipsychotic and a different combination of medications. So for me, going off medication was the wrong choice at that time. And I've thought about, do I want to reduce my medication ever again? And right now, the answer is probably not. I'm happy with my life. I'm relatively symptom-free, and I have a lot of people who depend on what I do, and I don't want to risk returning to having symptoms again. So right now, I don't want to reduce the medication, at least the antipsychotic, at all.
Okay.
Yeah.
I wanted to make the point also that one of the things we really don't talk about enough is how lethal these illnesses are. Untreated bipolar illness has a really high suicide rate. Schizophrenia has a less high, but still a very high suicide rate. And one of the things that we know about lithium is it is particularly effective in preventing suicide. There's fivefold, over 35 studies showing a fivefold decrease in suicide in patients that are at high risk for it. In any other branch of medicine, getting back to your kidneys and hearts, I mean, my husband's a cardiologist at Hopkins. They talk about death rates. They talk about mortality rates. They talk in oncology about death rates, mortality rates from particular kinds of tumors. We don't talk about death rates enough. People die. I mean, I was in a coma for several days from a severe suicide attempt. I don't want to die. I didn't ask for this illness. I love life, but at that time, I wanted to die and nearly died. These are things that, particularly in young people, particularly under the age of 30 with bipolar illness, is staggeringly high suicide, 80 times the national rate of suicide in people under 30. So this is something that, again, when we talk about these illnesses, first and foremost, keeping people alive is the important thing, and that's, the rest is you can try and help somebody if they're alive. You can't do much when they're dead.
What worries me, Jeff, is if, for example, you go off clozapine, it becomes less effective with each successive time you go back on it. So the idea of going off of it or even reducing it creates a risk, because then that you lose that opportunity for what could otherwise be an effective treatment.
Right.
Becky?
So I may be in the minority up here with my opinion, but I'm not anti-medication. I am informed choice or pro-informed choice. That said, I was told I was going to need to be on medication for the rest of my life. Nobody can predict what the rest of my life is going to look like, and what my needs are for medication will change depending on what happens to me in my life. And I've seen too many treatment plans that say that people will be compliant with their medication. That is not a treatment goal, people. People want to have a life, a meaningful life, and saying that you're going to be compliant with your medication regimen is not a goal.
That's why my son's in jail.
Well, let me just add something to try and clarify this, because it looks like there's a difference of opinion, and I don't think there needs to be. The reason why, if you don't believe this is an illness, like Thomas Zaz said and Artie Lang said and people have said, then of course you don't need medication. But I think nobody should really believe that, and it's a myth. If you do need medication for something, then if you have terrible side effects from it, people don't want to take it, or they want to take the least possible. And the first generation of medications that was developed, particularly for psychotic disorders and for depression, were pretty nasty medications, and the doses they were given in terms of causing side effects. So there was a real desire to either minimize the dose or find a way to enable people to stop them. Medications now are not brilliant miracle drugs that are mechanistically novel, but they're refinements. And this is the way pharmacology works. The first psychotropic drug in history was Miltown, meprobamate. It was, in a kind of sexist way referred to as mother's little helper. It was a minor tranquilizer, the forerunner of Valium. If anybody took Miltown, meprobamate, it's a pretty nasty drug. It makes you feel totally drunk and like discombobulated and everything, but at the time it was the only anxiolytic that was available. But then diazepam, Valium was developed, and chlordiazepoxide, Librium was developed, and now we have lorazepam and Xanax and things. And so these things, The antipsychotic drugs have been refined in a way to make the side effects less onerous. Brandon can tell you his migration from clozapine to Zyprexa to Abilify. The antidepressants also. So it's a process of finding a treatment that is not onerous that you can remain on. If somebody has hypertension, or somebody has diabetes, or somebody has epilepsy, you're not stopping your medication. You're not trying to stop your medication. What I tell people is, if you want to stop medication, that's your choice. I'll be glad to sort of give you my opinion. I'll be glad to tell you what the statistics say, but it's your choice. But really fundamentally says, okay, tell me what you would do if it was your son, your daughter, your husband, your wife. And then I tell them. And my God-honest truth of the matter is that if you have an illness that's well diagnosed, the prudent thing to do is to remain on the lowest effective maintenance dose. And if you want to tempt fate by going off it, you can. But I think it's a matter of you're playing the odds.
We have had quite a 2 days. I want to thank the panelists on this panel for bringing your expertise, your care, and your compassion to our discussion. I want to thank all of you who have attended and all of you who have brought your pain and your experiences into our discussion. We hope, the Sachs Institute, that this will be the beginning of a conversation that we will continue. From the number of questions that we did not get to, we can see that there is an enormous amount of work to be done. So thank all of you on the panel for speaking and contributing your time.
And thank you, Steve, for your great moderation, particularly in the heat of some of this discussion.
Thank you, Jeff.